Next talk is by Dr. Sony George. He's the regional, he's the center head at Agarwal's Eye Hospital, Kochi. And he'll be talking to us on how to offer multifocality to more patients.
A very good afternoon to all the delegates. And at the outset, let me thank KSOS for this opportunity and to all my co-instructors for the wonderful insights they have given into how to choose the ideal multifocal or how to customize a multifocal for the particular kind of patient. See, basically what I will be talking about will be how to offer multifocality for a larger number of patients. So in this, can I have the slides? Yeah. See, there were a few restraints which was keeping us away from giving multifocality to majority of the patients. One of the reasons was definitely the kind of photic phenomena, etc., which the patient used to have. And now we have come a long way from that, and we can offer with the newer EDOF lenses, etc., and even the trifocals coming out with a lesser loss of light in this particular kind of lenses. And also the economics, that also was very important. So these are the lenses we came through. So first was the economics. Now with the Indian lenses coming into the market, we have very good lenses which you can offer to the patient. So the economic factor also has been taken care of. Photic phenomena, like I talked about. Astigmatism, obviously you will need to give a toric lens in lens as mentioned by Dr. Minu, anything above 0.75. And a functional working distance for near and intermediate. That's what we are talking about. Nowadays, people do not read newspapers at 30 centimeters. It's around 45 centimeters. And now I'm going to talk about 3 lenses which can extend the number of patients I can offer to the Indian multifocals like the Region and the Define from Indian companies and the Indian EDOFs. There are 2 new EDOFs which have come into market. One is the Swiss Phobe by the Appasamy, which is a surface modified, aspherically modified surface, which gives EDOF properties, and also the Vivid, which is a EDOF lens by Orolab. It is a diffractive lens. And about the photic phenomena, like I said, if a patient who wants to drive and at the same time have a comfortable reading and intermediate, then I would advise Vivity to this patient. And AT Lara also will be an option, slightly less costlier option to the patient. And Panoptics and AT Lisa Tri also, like I said, have lesser photic phenomena. And if a patient doesn't drive extensively, I would still advise, and he wants to read, like a retired professor who drives, I would still give Panoptics or AT Lisa Tri. So the toric versions I talked about. And functional working distance, we have the Vivid, the AT or the AT Lara, the Vivity, and the Swiss Phobe. So Swiss Phobe is basically, like I said, aberration corrected with a central aberration correction which gives you good near vision, and the peripheral part which gives far vision. And here it has got an anterior refractive optic element and a negative aspheric design over the periphery which gives better depth even at low light conditions. And this is a comparable compared to the Minivel IOL. This is the kind of modulation transfer function which is pretty good. And in my experience, I have implanted around a total of 15 patients in both eyes, and the results have been pretty good. This is the lens being implanted. You can see the polishing of the lens is excellent, and from that the aspheric correction on the surface is quite evident. This is the lens. Nowadays they have also brought out the C-cartridge, D-cartridge kind of Actisoft kind of injectors which go in through a 2.2 millimeter incision. So this is the lens being implanted. If you look at the surface, you will get a very, very good surface polishing which is evident. And this is how the lens looks post-implant. And I've got uncorrected vision of around, in 66 patients, 6.6, and 6.9 in around 34% of patient. This is the far vision. And the intermediate vision, around 67% had N6, and 26.7 had N8, and 7% had N10. And the binocular uncorrected near vision versus the 66.7 got uncorrected near vision of N6, 27% N8, and 7% N10. Mind you, I always do a slight myopic residue in the non-dominant eye, which is also responsible for the N6, which is available in some of the patients. And none of the patients had any photic phenomena. And compared to the Technis eye hands, I feel this is much better. With Technis eye hands, I couldn't achieve N6 in any of the patients, N8 in 43%, N10 or less in 57%. So this features better than that lens, and even the magnificent lens, it is better than the eye hands, but then still I would place the Swisscope on a better platform. And this is the Auroview Vivid, which is called the continuous focus of vision. So this is what the normal, this yellow thing is the monofocal lens, and the other one, the bifocal or the multifocal, gives you better near vision, but more of visual distortions and slight intermediate vision. So this lens, this is the trifocal, which will give you more intermediate, and this is what the Vivid aims at. Minimum visual disturbances and better intermediate and near vision. So it has got a peripheral refractive zone, and the diffractive zone is in the center, which is around 3 millimeters and 4 rings. And refractive surface is on the anterior surface, and this is how it is. And either side 2.5 diffractive zone. So this gives much better intermediate vision and lesser photic phenomenon. And I have done around, this is a few months ago when I submitted the paper, around 5 patients bilateral implant, and this is how the lens is loaded. Basically, you just push the tip to fold the trailing haptic, the leading haptic over the optic, and then the implantation. This is the IOL which is implanted. You can see the rings which are seen very clearly. And this is the day 1 and day 2. This is 1 week, 1 month, and up post dilatation. The IOL is very well centered. There's no PCO. So here I get uncorrected distant vision of 6.6 to 6.9 in monoocular, and binocular it's almost 6.6 in all the patients. And the intermediate vision is N8 in uniocularly and N6 in most of the patients. And this is the near vision. One of the patients had N8, but the rest everybody had N6. And here again, I induce around minus 0.75 myopia in one of the eyes. Except for one patient, all the others didn't have any photic phenomena. And this has been talked extensively. The vivity is got the shifting and stretching of the wavefront, which gives better depth of vision as well as lesser amount of, I'll skip this because it's been extensively discussed. And so basically you have an extended range of vision, and patient has, the halo profile is almost similar to the actors of IQ, monofocal IQ. And again, so in my experience, again, I'll just skip this slide. I always do I don't have the privilege of having a femto to do the rexis, so I do a rexis marker. And you make sure, this is very important because ultimately the effective lens position is what is very important. So you get a perfect 5 to 5.25 millimeter rexis, which is very important because the effective lens position is ultimately a very important factor in these cases. And this is the lens. It's got a central zone. And this is the lens being injected. It is just like the Acris of IQ lens, but with a central area. So it's got a central 1 millimeter zone and then a plateau of 1.2 millimeter, totally making it 2.2 millimeter. And the central one shifts the wavefront while the plateau stretches the wavefront. So this is the lens being implanted and the cortical wash, which is very important. And these lenses, you can see the 3 rings in the center, the 2 rings in the center, plateau and the central area. You always have to go underneath and wash the IOL. And this is just to show that even these lenses can be implanted even in a case of a PC rent. Rexis in discontinuity. Okay, in a torn rexis. This happened during chopping, but then I have implanted the lens and it is centered very well at the end of the procedure. And this is how it looks like. So these are the post-operative pictures. The lenses are well centered. So to sum up, I would say, if a patient who comes with where finance is not a concern, he wants to drive, he wants to read and use the computers and other gadgetry at a reasonable amount of expectation, then I would recommend Vivity to this patient. For a patient where there is an economic constraint, definitely I would offer the Vivid or the Supra for this patient. And like I said, if you ask the patient whether he wants the entire range of vision, there's no patient who will say, I do not want. So just like all the other speakers mentioned, we have to titrate the expectations of the patient versus our expertise versus the type of lens, and that will get us happy patients. And this is my data. Thank you very much for the patient.
Thank you, Dr. Sony, for that presentation. Due to